You got 20 people on here.
You're live.
All right. Well, good morning, everyone. It is a pleasure to see you all on what is now, I think we're going into week 9, I think, this week of this very dynamic moment for Maryland and for all of us. This has been a busy 2 weeks. We did not meet last week, and so this is our first gathering in 2 weeks. We had, and I think the speaker is going to jump into this a bit more. Last week had a cancellation because the Department of Health, State Department of Health had canceled last week, and we wanted to make sure that we were using everybody's time wisely. And so we were told that was going to be made up today. I think the speaker will get into that later. In the meantime, I want to just kind of hit some of the big issues that have come up. First is that the speaker and I sent along, and believe every member of the work group has seen a letter kind of outlining some of the questions that we had for the Department of Health around testing, tracing, and isolation, and the details around the distribution of tests, the hiring of contact tracers, the deployment of contact tracers, the policies around isolation, so that we could have a really transparent process in place for all Marylanders. I think the more and more we go through this, all roads continuously lead through and to testing, tracing, isolation. That is the single most important set of policies, I think, that will get us not only to be better off on a public health front, but also to ensure that there is confidence in our economic system or in society as a whole, so that our economy can really kind of recharge and get back to where it once was. We had asked that information be provided by May 20th, today. We have not yet received a response from the administration on testing, tracing, and isolation. And then I think the speaker will address the issue today with MDH's appearance. I will say that the news that came out yesterday that there's an expansion of testing is great and very promising. What I very much hope is that it is not the same as the governor saying that the unemployment system has been fixed. So hopefully we will look under the hood and make sure that what is said is actually valid. Because unfortunately, when such statements have been given before, I think we've experienced it differently with our constituents and their reaction to it. So hopefully all is as is being presented, to be determined. On unemployment insurance, last week there was a lot of action. The Senate committees, Finance and Budget and Tax, did a joint hearing from hundreds of Marylanders who expressed their ongoing frustration with the system. The day after, the secretary presented to the Economic Matters Committee, and I think it's there where we first learned that about 130,000 Marylanders, despite being told that 90% of applicants were being served, 125,000 Marylanders, 130,000 Marylanders had been unable to access their benefits. So, the challenge with all of this is that statistics can always be played with. We've seen it happening in Georgia. We've seen it happening in Florida. We got to make sure that the numbers are what they are and that they're reported regularly. We're hopeful that those will get fixed and that there's progress, but to be determined. I think, at least according to my own personal experience with the 46th district, we still have about over 100, I think it's 115 constituents who have not yet had any progress on their unemployment insurance claims. Last and finally is the Board of Elections letter that the speaker and I sent yesterday to the State Board of Elections regarding the mailing of ballots. Certainly this is something that none of us, this is an election that nobody could have foreseen how it would transpire. The Board of Elections is certainly under some really extraordinary sets of circumstances. That said, I think there is some justified frustration with how things played out on the April 28th election, when we learned of a number of ballots that didn't quite make it in time for the special election. And then the delayed ballots to Baltimore City and parts of Montgomery County. There was an article in the Baltimore Sun today that reference letter. I will say on a very positive note, it sounds like the Board of Elections will be moving forward with expanding the number of in-person ballot drop-off locations in jurisdictions that have delayed ballots. At the end of the day, Education, Health, Environmental Affairs, and Ways and Means did a joint hearing last week. This is a really odd election, but it's important that we get it done because we don't know what November may look like. And we want to make sure that we learn from the experience of April 28th, as well as the upcoming election on June 2nd, so that we can inform, in the case that a mail-in election is necessary in November, that we have kind of the best possible policies in place so that the general election can be run as smoothly as possible. It's certainly an important one across the board. With that, let me hand it over to Speaker Jones.
Okay. Thank you. Good morning, everyone. And as the president mentioned, the House and Senate both had unemployment insurance hearings last week. And I want to thank Chairman Davis in particular for pressing Secretary Robinson to answer regarding the ongoing problem with the Beacon system. I joined the ECM hearing and was struck by the overwhelming concern from both Democrats and Republicans on how this system has continued to plague Maryland residents desperate for help. I know Chairman Davis is looking forward to responses to his 4 pages of follow-up questions from the department. Unfortunately, the Maryland Department of Health canceled appearing before the work group yesterday, still again. As the lead agency in this pandemic, we have repeatedly asked for their attendance. I believe this was the 4th time, to no avail. We are hopeful they will come next week to answer all of your questions for the full hour of the work group. You two are elected officials reporting and representing to the people of Maryland and deserve answers. With that, Mr. President, I will turn it over to you to introduce our first guest.
Thank you, Madam Speaker, and agreed. And along those lines, we also, one note that I forgot is certainly the most, one of the most impactful changes that happened over the week was the recovery movement into phase 1 recovery for some parts of the state, with local discretion being delegated from the authority of the governor to the local jurisdictions. That has yielded a variety of different rules, regulations, and policies. And that has left each local jurisdiction to come up with its own set of rules and categorization for movement into phases. We've seen some counties work together, other counties choose separately or their own independent standards. And so what we thought would be helpful today is to have representatives from local departments of health. I'm incredibly thankful, and I know the speaker is as well, that we do have our 3 health officers here today that are presenting, just to make sure that you will note that all of them are from the central Maryland area. We had invitations to health officers from the Eastern Shore and some of the other Southern Maryland and Northern Maryland, kind of Upper Eastern Shore counties that were unable to attend, and given their independent schedule. So we are hoping to have them as well. We wanted to have kind of representatives from each of the different, one where there has not been any movement towards phase 1, where there's been a slight movement into phase 1, and then where there has been full phase 1. So it was logistics and scheduling that we were unable to get the other ones, although the health officers from the Eastern Shore were pleased to hear who would be presenting, because they've all been working pretty collaboratively at the local health departments and thought that it would be a good representation. So just wanted to make sure that I kind of clarified there about who is appearing today. And we would ask, each one will give a quick presentation overview about how they are proceeding in their independent jurisdiction. And we will hold questions until after all 3 of the health officers have completed their presentations. And then they are all able to stay on to answer questions after all 3 have completed. So without further ado, I would like to welcome Dr. Nilesh Kalyanaraman. Was I close? From Anne Arundel County. I've tried to practice a couple of times, but otherwise known very well and reverently as Dr. K. who has been very much out front and talking throughout this pandemic about the importance of public health. So without further ado, Dr. K.
Thank you, President Ferguson, Speaker Jones, for having me here today. Wanted to talk to you a little bit about what we are doing and seeing in Anne Arundel County and how that meshes with what's happening with the state. I agree with your assessment about the testing, contact tracing, and I would add case management as a key part of the work that we're doing. A lot of what we're seeing is in COVID is layering on the health disparities that we saw even prior to COVID, and it's just revealing those issues. When we look at our body of work, education is a key part of that, and the testing piece is key to that. I know that we're in the process of expanding criteria around testing, and what we're really looking at is making sure that as we're going through our recovery that we have certain benchmarks that we're meeting. So for testing, that means that we're trying to get that test positivity rate below 10%. And we've set that mark because from decades of work with respiratory pandemics, it's clear that to have sufficient confidence that you're getting the vast majority of people who have COVID, you need to have enough testing to be able to find every one of them. And a good marker of that is getting that positivity rate under 10% and closer to 3%, frankly. As a county, our positivity rate peaked at around 30%. We're down now to about 15% and heading in the right direction. But it is one of the dashboard measures that we have, and we have a range of measures that we're using to monitor our recovery. In terms of testing capacity, that's coming on slowly but increasing. We have test capacity that operates 7 days a week. On Mondays, we do walk-up testing through various communities, and it's targeted to actually communities of color because we know that there's a disproportionate impact of COVID. We see in Anne Arundel that we have a mortality rate about 50% higher in African Americans than we would expect based on demographics. In the Hispanic population, we're seeing about 3 to 4 times as many people positive as we would expect based on demographics. And so we're intentionally doing that. We've been moving around the county and have been 10 different sites doing that walk up. On Tuesdays and Thursdays, we do drive-through testing in Annapolis at our health department. And on Wednesdays and Fridays, we do it in Glen Burnie vehicle emission inspection site in concert with NDH. We also do targeted testing for vulnerable populations in congregate settings, shelters, nursing homes, jail, our correctional centers, assisted living facilities, that type of thing. And we continue to, and first responders, sorry, and we continue to ramp that up. We're, and I'm gonna really thank Dr. Gales from Montgomery County. He's been one of the leaders in identifying additional testing capacity on our own. We're using his leads to identify additional commercial lab testing capacity. We've been promised additional tests from Maryland Department of Health. Just got a notice yesterday that we'll be getting an additional 500, at least our county will, additional 500 tests per week. And we're hoping to get receipt of that soon. So the testing capacity continues to increase, and it continues to be a key part of what we're doing. We've also set a measure of we want to test 2% of our population each week as a way to get enough surveillance out into the community as well, so we can identify any potential hotspots that are starting up. Contact tracing has been a core part of what we've been doing. We have over 3,000 cases at this point, and we've contact traced every one of those cases. We built out our capacity from largely from other staff that we reallocated to our contact tracing program. We have over 101 people now. We have 101 people now doing contact tracing in our department, and we're looking to switch that to hiring new people using some of those CARES dollars to hire new people in, because that is going to be an ongoing part of our work. And key to that contact tracing is really that case management that I mentioned. When we're calling people, doing that initial contact tracing, we get a variety of responses. We get people who are thankful. We called people who are concerned about how they could possibly manage isolation and quarantine, and then people who don't want to do it. And a lot of our work has been around talking with people, talking through their fears, their concerns, and also their material needs. What do they have? What do they need in terms of food access, housing issues for those who are either homeless, marginally housed, or don't have adequate housing to be able to do the isolation and quarantine. A family of 5 or 6 in a 1 or 2 bedroom apartment is not going to be able to execute what we need in terms of a public health standard around isolation and quarantine in the same way that somebody in a larger house may be able to. So we spend a lot of time and resources in concert with other county agencies, for us as City Annapolis agencies and nonprofits in the community to solve those issues. We right now we're renting hotel rooms to be able to house people, and that's going to need to be an ongoing part of our response. The other part of it is that right now we're in a period where there are federal benefits around unemployment insurance and guarantees for jobs. But in order to be able to continue this work, we're going to have to have a situation where people's income and jobs are going to be there for them when they go back from isolation, and particularly from quarantine, which is a little bit harder to manage. And that's when people don't have symptoms, because without those guarantees, we're putting people in a very uncomfortable position of choosing between how they do with an illness or whether they can feed their family. And right now we're okay, but that's one of my asks to you as our state legislature to address that issue going forward. And then the isolation and the quarantine I mentioned as part of this, many people can manage this on their own. But for those who can't, we need to be able to continue to provide supports. And in terms of that contact tracing and that case management, I know that the state is setting up their system and we're in conversation with them. Actually, right now, there's a meeting with my department and the state health department around the online platform to be able to manage that contact tracing. But we think that case management is so critical. We're actually going to be doing the initial contact tracing out of our health department. We know the difference between what's there in Odenton and Deal in Southern County and up in Glen Burnie and out in Severna Park. Those differences matter for people being able to execute the isolation and quarantine. And then we'll kick out easier cases, straightforward cases to that state system where they can do some of that more routine work where you don't need to know those particularities as much. That's kind of the general framework. We also have a dashboard for recovery that we are using to guide our progress through this recovery. It includes mostly it's consisted of the elements that are laid out by the governor: hospital surge capacity, PPE, testing capacity, contact tracing, looking at our cases and our deaths in the community. And then we've also added health equity as a key dashboard that we're using so that we can make sure that at-risk and vulnerable populations don't get lost in the mix. An average is just an average, but there are people at both sides of that average. And we want to pay attention to that at-risk population. And so with that, I'm gonna wrap up. I know there'll probably be questions, but I want to leave time for my colleagues from Montgomery and Howard County. So thank you.
Thank you, Dr. K. We are also joined today by Dr. Travis Gales from Montgomery County. Dr. Gales has an extensive background in health disparities. He is leading the effort to expand contact tracing in Montgomery County. Currently, the county is tracing about 60% of the cases in Montgomery. Dr. Gales, thank you for joining us.
Thank you, Speaker Jones and President Ferguson, and to the other elected officials on the calls, and to my colleagues from Arundel and Howard. After Dr. K's presentation, I don't have a lot to say. He nailed it in terms of mentioning things and what they're doing. So thank you for the opportunity to share with what we're doing in Montgomery County. As you all know, we have the second highest number of residents who've tested positive with COVID-19. And that does present challenges, particularly also given our location close to the Northern Virginia area and the District of Columbia. So we have worked very closely with our colleagues in the state of Maryland, as well as working very closely with our National Capital Region partners to figure out how we move forward and to discuss strategies in terms of how we can collaborate. So just want to highlight a couple of areas and things that we're working on. Again, Dr. K laid out some significant issues or thoughts around contact tracing. We too are working with the state through their system to provide additional support to be able to follow up on cases. We had been following cases from the very beginning. And then as the volume increased, we created a priority system that focused on congregate living places, including our nursing home settings, pediatric cases, and any individuals who fell into what we had described as the vulnerable communities, including those who were over the age of 60, as well as any of our first line responders and healthcare workers. With the additional support and resources, we've been able to expand, and then going back to filling that donate, we're prospectively addressing all of our new cases that are coming in and closing that window to get that other 30% of cases that were maybe missed through that prioritization system. So the first bullet I want to talk about is we have worked hard to create I've been calling it a buffet of testing options, because we recognize that access to testing and access to medical care are things that just didn't arrive with COVID-19. They're longstanding issues, and we've worked hard to create options for the citizens across our jurisdiction. Like in Arundel and in Howard, we do utilize our vehicle emissions station in White Oak to offer testing. We have expanded beyond that, and we've created and using community resources, including the Wheaton Recreational Center, as well as the Upcounty Regional Service Center in Germantown, to also offer opportunities for folks to do a drive-through testing mechanism. Now, even within that, we recognize that lots of people still did not have access to a primary care provider or a medical provider to get the needed referral to get a test. And so we created a mobile testing helpline that went live last week. And so individuals can call in and get triaged and screened using our medical volunteers or linked to one of our safety net providers, and then get referred to any of the alternative test sites that we have within the county. And if they don't have insurance, that's not an issue. We can see them and get their test processed and get them the results in a timely manner. In addition to that, we are creating a mobile testing arm to be able to go out and do pop-up testing at different sites, recognizing, as was brought out already, recognizing that there are spaces that are more transportation friendly and accessible, but also in places that people trust, because we recognize that during this time, a lot of issues in terms of access or mistrust of the medical system has prevented a lot of people from moving forward and accessing the services that they need. And so that arm will also partner with our human services colleagues and also providing a case management component. Now, we have worked with the state to some degree around ready responders. The health department has provided access to those teams. And so those teams for the last 3 to 4 weeks have actually been going out, working with our community partners who've identified families who are in need to do testing in people's residences. And so we've met them where they are. They've also helped make sure that we've tested our high-risk populations in our shelter community to make sure they have access to testing services as well. And we are building a local version of that, again, as I mentioned, with our mobile testing arm, and pairing that with our case management system through human services, because we found that clinically a lot of folks are stable, but a lot of their needs are tied to food security and other types of things. We will be announcing a high throughput testing mechanism very soon. I'm waiting for the ink on the contract to dry before making that announcement. But our goal is, we recognize as we move forward, again, consistent with Dr. K mentioned, we want to increase the capacity to test more folks. Not only increase the capacity to test more folks, but change the criteria. So recommending that individuals, particularly who are asymptomatic, are getting screened and tested, including our essential employees, everybody who we've asked to come to work to keep us moving in the last 6 to 8 weeks, because they've been exposed. And so we want to create opportunities to test as many of those individuals as quickly as we can, because we feel strongly that if we can identify those asymptomatic cases, get them quickly isolated and interrupt their networks of transmission, we can prevent them from unknowingly spreading to other folks, and again, drive down that number of new cases. So we'll be announcing that very shortly, but we will prioritize essential workers, healthcare workers, first line responders, as well as making sure that we shore up and make sure our nursing homes are taken care of, as well as our assisted living facilities, because in Montgomery County, we've been really hit hard, unfortunately, in those settings. I think we've already talked about the contact tracing component. We will be working with the state on that. We've also partnered with our academic partners at George Washington University and University of Maryland to receive consistent feedback on how we can continue to improve those processes and increase our capabilities from an epidemiology standpoint to be able to provide data more readily and be able to identify potential clusters of transmission to interrupt them as quickly as possible. We will also be launching a dashboard that will track all of our respective measures. They're very similar to what has been laid out. We're looking at a decrease in the number of new cases. We're looking at, from a hospitalization perspective, making sure that we have adequate acute bed space as well as intensive care space, because we know that as things get relaxed and we shift away from some of the more restrictive policies, there's always the risk of seeing a spike in terms of cases. So we want to make sure before we reopen on a phase 1 or phase 2 level that we have some hospital capacity to be able to absorb that if that happens. And our testing goals are to make sure that we have the capacity to test 5% of our population on a monthly basis. And like Anne Arundel, and I'm sure Howard as well, we're looking at this from an equity lens. Because the reality is that all of the disparities that we've seen in our county, Black residents have a higher rate of death, COVID-related fatalities, and we do see higher rates of new cases in the Latino community in particular. So, but none of this should surprise us because the same disparities that we're seeing playing out related to social determinants of health for COVID-19 have been present for decades. And so we're making sure that in our efforts to address COVID-19 in the short term and long term, that we're looking from a health and all policies approach, and we're making sure that the policies that are put into place are going to address the systemic issues that continue to contribute to these particular disparities. I will stop there. Thank you again for the opportunity and happy to answer any questions that you all have.
Thank you very much, Dr. Gales. Next up, we have Dr. Maura Rossman, and I want to thank Dr. Rossman, who came in, was able to come in at the last minute to help to fill out our panel here. So we really greatly appreciate it and know that you're very busy. So appreciate your presence here today. Please proceed at your convenience.
Yeah, good morning. Thank you for having me, Speaker Jones and Mr. Ferguson. And I do need to jump off. I won't be able to stay on the full call. And thank you to my great colleagues, Nilesh and Travis. And I guess I'm going to do the cleanup. They've done a really incredible job of laying out, similar to Howard County, what we have been doing, describing anything from the health disparities. And I'm going to just talk a little bit about the three-legged stool that they have both mentioned: testing, contact tracing, and PPE. To give, Howard County is a medium county. You know, we're smaller than Anne Arundel and Montgomery, but surrounded by our large counties, particularly in the capital region, where we are seeing sort of hot spots and higher areas of COVID cases. And of course, no man is an island, and we recognize that Howard doesn't function alone. We function with our brothers and sisters around the state. And Howard has been, like Anne Arundel and Montgomery County, working with both the state and local government to achieve our goals. And we too have been evidence-based and data-focused. Just to bring out one perhaps difference or something that others didn't have the time to talk about. In Howard, we have been working towards, I'm going to call it a public-private partnership for that three-legged stool that I talked about. Number one, testing. Yep, just like the rest of every single jurisdiction in Maryland, we need to increase our capacity for testing. We too have a VEEP site that is run by Howard County Health Department. But in addition, we have the hospital, who has their tent open 5 days a week, where providers in the community can refer residents for testing. We have 2 urgent care centers that operate either Monday through Friday or 7 days a week, where residents can on demand go for viral diagnostic COVID testing at no cost to the resident. And we continue to explore more what I'm calling public-private partnerships to expand our capacity. Howard County Health Department, we have the most fabulous staff, but we're limited to 200 staff, and that is just, quite frankly, not enough to continue all the expansion that we need to do to respond to this pandemic. So again, looking at other options, including these public-private partnerships that in Howard County we are fortunate to have. In terms of, again, the contact tracing, we too, like the rest of the state, are working with the state platform to come on board next week. We too have redeployed, reassigned as many staff within the health department to work on contact tracing and case investigations. And we are currently in the midst of interviewing, I'm calling them temporary contingent staff, to continue that work. And that is absolutely incredibly important as Maryland and Howard County gradually reopen, so that we can identify those residents who are infectious and get them into isolation, or their contacts into quarantine, so to continue to slow the spread and not see a surge. And we are working with the county on looking at other vendor options and novel ways that other countries, other states have used technology to reinforce or amplify particularly contact tracing. And last, I'll talk about PPE again in terms of public-private partnerships. We were incredibly fortunate that a number of residents, a number of organizations, both large and small, have donated personal protective equipment that we are able to and are on a daily basis providing to prioritize lists, which now include our primary care providers who are trying to reopen. One of the aspects of COVID shutdown was that there are now many people who have not been able to get their routine health care. And we don't want an unintended consequence of our safer at home and safe at home to be that at the end of all this, there will be folks with pretty significant health issues because they have not gotten either their preventative screening or have not gotten the care that they need sooner than later. So we work with we have been pushing out, we try to estimate our first week supply to our community providers and then provide them with information so that they can continue to maintain a supply to continue to see their patients. I'll end with two other, I think, points. We also, unfortunately, 50% of our deaths are related to those living in congregant facilities, and that's consistent with the state as well as nationally. And we spend a lot of time daily with those facilities ensuring infection control processes and working with the state as universal screening of these facilities is ongoing. And last, but probably maybe most important, Howard County is a very diverse county with more than 50 different languages spoken by our community. And we every day try to push out information so that our residents have credible, reliable information at their hands in a variety of different languages, in a variety of different formats, so that they can make the best decisions for themselves, for their families, and they know who to contact if they have questions. And I'll just take this opportunity to give a shout out to the public health workforce in Howard County and across Maryland, who has not taken a day off since this started. And we don't complain. We get up every day, just like our first responders and healthcare workers, to try to reach the needs of our community. And I thank you for allowing us to speak. I hope you do get the opportunity to speak to the other fabulous health officers that we represent. So thank you.
Thank you, Dr. Rossi. How much time do you have? We're about to take questions. How much time do you
All right, so I'm already 4 minutes late. So I could probably stay on for another 10 minutes and they'll have to forgive me once again.
Okay, all right. Our first question's from Delegate Pena Melnick.
Thank you. Good morning, Madam Speaker. Good morning, everyone. So the question I have for all three officers, and thank you for your work. I know you're doing really hard work. We appreciate you. How many tests have you received from the state before yesterday's announcement? If you could tell us that. And if you know, are any of those tests from Korea? And then also, do you know if the labs have begun processing some of those Korean tests? And my last one will be, how many nursing home strike teams have you been involved? How many have been requested for your jurisdiction? Thank you.
I'm happy to start. This is Nilesh. I don't actually have a good way to answer the question around the number of tests that that were specifically from Korea. We get some limited testing supplies from the Maryland Department of Health that we've pretty much exclusively been directing towards congregate settings and first responders. My understanding is that the additional tests that are coming now into our VEEP sites and into our health department is probably a representation of that. But from certainly from my perspective, I don't ask where the tests come from. I just want more.
Hi, this is Travis from Montgomery County. So much like Nilesh mentioned, it's hard to quantify. I don't know if, what I would say, I know that we have received kits related to the very beginning where we got kits. I think we all got a manila envelope of kits when we were still in the early stages. And I do know that we have benefited from the ready responder teams that have been a part of the health department. And those, from my understanding, were sent out to the jurisdictions that had the highest number of cases. And so they have tested a number of residents in their homes, they've tested their shelters. I don't have an exact number, and I do know that they've started testing in some of our assisted living facilities, and all of those tests are sent through the state system.
Yes, and I'll just follow up. All of our tests that we have used in our congregant facilities come from the Maryland Department of Health, and I too don't know if where they come from, Korea or wherever the state accesses them. We're just grateful to have them. At our VEEP site, we are using labs from Quest that we have privately contracted with. In terms of the GO teams in the nursing homes, we've availed ourselves of every single team. And I think this week they are at 3 different nursing homes.
I will jump in, and if other senators have questions,
There's a Senator Rosenpepper.
Oh, yes, so there we are. Senator Rosenpepper.
Well, go ahead, Mr. President.
Sure. Sure. I'm curious about your perspectives now that the shift happened on Friday to a more locally driven approach to recovery. Certainly the state is incredibly fortunate for the expertise that the three of you bring to your respective jurisdictions. There were a couple places where I noticed a few differences that your counties are focusing, 2% a week testing versus 5% per month. Minor things that may end up being the same kind of net impact. But as the counties have different approaches and as there is sort of more local discretion on the recovery phase and kind of moving partial phase 1, full phase 1, phase 1.75, how are you all approaching that, and how are you all seeing your roles as local health departments there?
I'm happy to start. So we've, even though, yes, there are some nuances and slight differences in our metrics, we all met to discuss the metrics. So at least, we've had conversations with our state colleagues, Maura and Alesh. We've also had similar conversations with our colleagues in DC and Northern Virginia to make sure that we're all, even if there's some differences, we're all on the same page as we move forward for the reasons that we've outlined. I'll be perfectly candid. We would have preferred there to be more of a state-led effort in recognizing the challenges that different jurisdictions have, as opposed to leaving it to us to figure out those metrics. As you can imagine, it's created a dynamic where we have had to be put on the defensive, quite frankly, as local health departments in terms of justifying why we aren't opening up and why our metrics don't match up. It has been tricky, but we are working again with our colleagues to make sure that we're collaborating as we move forward. We are continuing to think through strategies. For example, I've got some calls with some folks, again, colleagues in Northern Virginia and DC today to talk through what a phased one approach looks like. So, as we move forward and as the numbers look more favorable, do we go full throttle and say we're going phase one in terms of everything that the governor has laid out? I am quite frankly nervous to do that based upon what our numbers look like today. I think we may be able to open up some opportunities and explore some of those, but I'm not sure we'll be able to achieve the full level of phase one opening that the rest of the state has from Montgomery County.
Thank you.
Yeah, I want to echo what Travis is saying. I think the challenges that we've been confronted in approaching this at a county level, one, a state level approach gives more uniformity across counties, and that we are some of the bigger counties. I know for the smaller counties, they don't have the staff to be able to address all of these individual issues that businesses have, and that's a significant concern. The other part of this is that we're usually given no warning about what is coming. We the governor's live feed along with everybody else, and then are put in the position of reacting to it. And that is a difficult, and as all of you know, nobody cares that is our time pressure, but that is the time pressure we operate under. And so going forward, I think that we will continue to collaborate as health officers and health departments. We will continue to, but that we are not the only part of this. Certainly the business community, social services are all involved in this. And so that sort of coordination gets really difficult across counties when it's not done at the state level.
I'm going to add a little bit of perhaps a different perspective. So, we're in uncharted territory in terms of approaching this pandemic. And of course, we can look at historical data and try to compare it to other pandemics, but we're all trying to figure out data points and metrics from research papers, academic papers, and coming up with quantitative numbers because I think I started when I spoke, right? We're evidence-based, data-driven. So any decision, Dr. Rossman, what are we going to do? What number do we apply it to? And we come up with the best numbers, but I'll be honest, I think the numbers may need to be revised as we learn more and find out more as we go forward. So I try not so much to try to focus exactly on a particular metric or number, but what is the impact and what, of course, are we trying to achieve? And basically what we're trying to achieve, I think, across the state, but certainly I can speak for Howard, right? Is we're trying to find out who right now in the community is infectious, get them into isolation and their contacts into quarantine. Whether how many or what number that is, of course, we have to figure out because that has to do with supplies and other efforts, staffing that we need to do that. But at the end of the day, that's what we're trying to do. As the country, as the state, and as the county prepares or to plan for reopening, we have to be able to monitor this. And again, and that's where I think Nilesh spoke about, and Travis, about hospitalization, acuity, vents, and other aspects to this infection. But in some ways, it's a moving target. And I also recognize that in Maryland, what happens in Garrett County there is very different than what's going on in Howard County. And I think we do need to be respectful that there are differences regionally and population-wise among the 24 jurisdictions. And I think there needs to be consideration among the different jurisdictions for nuances, I think, as Travis says, as we reopen. The challenge is, I don't think just in Maryland, but I think it's nationally, the communication of all this. I think the public, I'll admit sometimes I'm confused, and I certainly think that the public is confused that as we talk about reopening, suddenly we can all go out without masks, social distancing is not so important, and suddenly safer or safe at home becomes no longer needed. And that's a concern for me, because this pandemic is going to be around for quite a few more months. It's not going away, even though we are hopefully getting it in better contained and better able to mitigate the spread. But it's not going away for some time. And I think that is what we all need to communicate as we reopen, that things may need to be adjusted and pulled back accordingly based on what we're seeing.
Dr. Rossman, I just want to say thank you. And I know you were able to come in the last minute and want to be respectful of your time. We really, really appreciate your perspective.
All right.
And thank you for answering those questions.
All right, thank you.
Thank you.
Bye-bye, Nilesh. Good seeing you, Travis.
Madam Speaker.
You have.
Oh, Senator Roosevelt, do you want to jump to Senator?
Roosevelt.
Okay.
Yeah.
Senator Roosevelt.
Yeah, thank you very, very much. First, I just want to say that I have been so impressed with the health officers and the health departments around the state. I'd say 90% of my experience with health departments has come in the past 2 months. And I'm just incredibly impressed with everyone I've dealt with in terms of their transparency, in terms of their positivity, in terms of their professionalism. And particularly now that it's becoming more clear, the lack of cooperation, frankly, between the state and the local governments on this stuff. I'm also impressed with how the local health departments and counties are working together with each other when they're not getting the kind of support they need from the state. So just want to say that. My question is this, and it goes to the communication issue that Dr. Rossman was talking about. I find a lot of my constituents really confused about testing. Not that they don't think testing is important, but whether they can get tested or not. And that's been the sort of communications level at the state level, is who should be tested, who shouldn't be tested, who can be tested, who can't be tested, are there tests, aren't there tests? And I've heard that in some cases, some counties have had more tests than they have had people ready to test because people didn't think they could get tested. And I wondered, do you all have some experience with that? And going forward, now that we are expanding testing in a big way, which is terrific, how we can all help make clear to people that they can be, should be, and will be tested when appropriate.
I'll give it a stab. I think that what where we started at was that we wanted to test. When we look back to the beginning of March, we wanted to test anybody with symptoms, and we didn't have the testing capacity, and that we weren't unique in that. And what's happened is that all along our testing capacity has slowly increased, and we've tried to increase the criteria and try to get more people in, but that's a confusing message to communicate, particularly when it changes every week to 2 weeks. I think the timing is such that right now we're in a position to say, if you have symptoms, or even if you don't and you just want to get tested, you can. And so there's really not much more for that message to evolve anymore. So I think we've gotten at the place we always wanted to be. And so I think that'll help with the messaging going forward. Travis?
Well, I don't have much to add other than, the evolution of testing and testing criteria has rapidly evolved. And I mentioned that manila envelope. I mean, I very clearly, I was talking to a disease control manager yesterday where we had the manila envelope where we were going out parsing, like sending some kids to a nursing home to do a contact investigation. 8 weeks ago, and look how far we've come. So I think that's part of the challenge, and I think it speaks to, and this isn't the subject of this call, but I'll be candid. Part of the challenge is that the public health infrastructure is not a modern infrastructure. And historically, when there have been budget cuts, not necessarily at a state level, but at a federal level, the public health enterprise is frequently one of those places that has cuts. When we're talking about contact tracing, many of the folks who have historically done contact tracing are a disease intervention specialist. DIS workers have seen their numbers cut over the last 5 years or so. And so I think it speaks to the need to invest more in the public health infrastructure, particularly around the ability to effectively communicate in timely manners, to be able to disseminate information to, as you mentioned, the populations that are struggling to figure out, well, what is it today? What's the new news? What's the new update? And in the absence of those types of mechanisms to get that evidence-based information out quickly, people will utilize a lot of spaces from social media to other platforms that don't always have the most up-to-date or the factual information that they need.
Okay. Chair Pendergrass?
Does that work? Can you hear me?
Yes.
Wonderful. So first, I want to thank both of you and Dr. Rossman and all of the other health officers around the state. I know that you have been working very hard and doing a very important job, and all of your employees as well. And I think there are even some volunteers and something like, I can't remember the phrase we use, but for the volunteers that have signed up to try to help in this difficult time. I'm concerned about a lot of things. The most top of my list at the moment is the fact that I know that I sent something to the department through Webster Yee on May 10th. And I know that the speaker has sent a couple of letters, one with the president and I think one with Maggie McIntosh, and I may have even been on that letter as well. But I know there are letters and they go by the Department of Health as unanswered. And I gather that we're getting the same lack of response and that you are. And that is, it's disheartening that it's happening to us because we're trying to help you and the citizens, but it's incredibly disheartening that you're not getting as much help as you might need. And I'm not sure what to say about it, except that I think it's important to put some things on the record. So I'm going to ask a couple of questions, if I may, and I'd like your opinions on them, though you may not have answers. I know that there has been a directive that, let's see what the words are. All licensed health facilities and healthcare providers may resume elective and non-urgent medical procedures and appointments, provided all the following measures are in place. And a big part of the measures has to do with protective equipment, PPE. I've heard from the dentists in particular in Howard County, but I'm sure it's true all over. They absolutely can't find legitimate PPE, that what they could get, and they've looked at it, and I trust the people I've spoken to, is fake equipment. To put a dentist in fake equipment and have people coming into his office or her office to do any kind of procedure where they're aerosolizing, whatever that word would be, of the droplets are all over the place, would become a public health issue. That would be a super spreader, I presume. So the new directive says that they can do both elective and urgent procedures. I'm wondering if you know, if we were to ask the governor, and maybe we'd get a response, to change that to urgent and emergent and have them consult with the dentists, because these issues send people to the hospital and even kill them, frankly. And as we remember with Diamante Driver, so that they would be able to be put on the list of essential emergency personnel so that they might be able to access the state's supply of equipment. Do you have any comments on that issue?
I'd be happy to start. I'll take this one. So the first thing I want to highlight is for our colleagues at the State Department of Health. So I want to be clear that Deputy Secretary Phillips and her team have been responsive to us in terms of addressing our concerns. She and her team have participated in weekly calls with us 3 times a week to provide that feedback. So I want to make sure that you all understand that we have valued that relationship and have received a lot of positive feedback and guidance. And so to your question related to dentists, so what we are doing is we have taken those guidelines and we actually have a county dental program, and our dental director is coming up with guidelines to be able to provide to dentists. We have asked that if folks have PPE concerns, they can send them through our command center so that we can try to be able to address, provide some provisions of PPE for them to be able to reopen. But we have heard a significant, particularly from dentists, we've heard a significant amount of concern about the readiness to reopen based upon that criteria. And what I can say is we don't have a lot of dentists rushing out to reopen right now. They're a little nervous and waiting further guidance.
Yeah, I'll build on what Travis said, is that we do 100% agree that our contacts with folks at MDH have been really positive. I'll just note that sometimes they get caught off guard too, and that's a challenge that the folks that we're interacting with are sometimes in the same boat as us, and so I think that's more of the issue. And in terms of dentists, we have. I agree with Travis. There are a few practices that are looking to open as part of our PPE distribution. We as county are purchasing some PPE. We also get through MEMA into our EOC, and then we have a distribution plan across a variety of different groups: hospitals, nursing homes, dentist office, first responders, that whole system. And so we are able to push it out and push out PPE, and that's based entirely on requests. So there are some opportunities to get that PPE if they're not able to source it on their own.
Senator Hershey.
Thank you very much, Mr. President, and for everybody that had their presentation today. Just a couple questions. I think we can all agree that the efforts of all Marylanders has been effective in flattening the curve and also in mitigating the surge on our healthcare facilities. Now it appears we have shifted our focus more onto a potential spike in new cases. So rather than focusing on the hospitalizations and the intensity of that virus in those infected, we seem to be hearing more now about the number of new cases and an impending and inevitable spike that might be occurring. So I'm just wondering, how is this risk of a spike affecting the advice that you're providing your respective county executives for their decision-making in either implementing or delaying phase 1 openings? And then 2, notwithstanding the decisions of the governor at this point in time, but we've seemed to move to a more of a county by county decision-making process on what businesses can be opened. And I'm wondering, aren't the health officers in those counties just as capable of providing advice to allow expanded levels of opening, possibly even exceeding phase 1 and entering into phase 2? Thanks.
I'll give it a go. In response to to that question around being able to go further, right now we're still limited by what the governor has allowed. So in his executive order that came out last week, it said you could go up to these things, and as a county you can choose to do less than that. But we don't currently have the ability to go beyond what the governor has allowed as part of that executive order. That doesn't mean we're not planning for those, and we're certainly and our county executive is meeting with folks from our economic development council and others to look at how we map that out and provide the guidance to be able to do that. With respect to additional cases, we know that as we liberalize and open up more sectors, we're expecting to see additional cases, and I think that's where that real focus on testing and contact tracing, isolation, quarantine, and case management comes into play. I really think of that as the individualized stay-at-home order. You know, we had that blanket stay-at-home order because we needed to build up our infrastructure, not just hospital capacity, which takes care of people when they're sick, but how do we slow down the spread so not as many people get sick? So now in that process of building it up, we're able to get to people faster, test them more quickly, and pretty much give them personalized stay-at-home orders so that we can slow that spread down. I really see it as a stepwise kind of function. We're going to go along. We'll see a little increase. We want to bring it down before we start going up again, because with something like this, where you see exponential growth, once it starts taking off, it takes a lot of effort to put the genie back in the bottle.
And I would add, you know, from the Montgomery County perspective, honestly, we haven't achieved the goal of being off the first wave yet. So while we've seen the improvements in the curve, you know, my main advice is around mitigating that. Certainly thinking and anticipating a potential for a spike in the future, certainly. But right now, we still have a tremendous amount of work to get our numbers down to a place that's comparable to other parts of the state. And so I think that, to the question, the point that we have emphasized thus far is that we are working together as a region to think through how we can move together, recognizing that a lot of our residents, work, play, live across the borders and boundaries. And so we just want to make sure that we're consistent in moving forward.
Thank you. Did you have another question, Senator Hershey? Oh, he's on mute.
Yeah.
Did you have?
Yeah, thank you. No, I just wanted to follow up on that, and like I said, I can appreciate that, but a lot of people, again, where I'm talking to in my district here on the Eastern Shore, we're certainly talking about the Labor Day weekend, the summer coming up, and being able to get businesses open. And we're seeing a kind of a difference in what the governor has allowed. Some counties deciding that they're not going to implement as much, but yet other counties asking to implement even further. And I think for the general public, they kind of need to know where these goalposts are. And my question was kind of related to the fact that I think most people thought the goalpost was flattening the curve. And now it seems to be that the goalpost has been moved to potentially mitigating a potential spike that might be down the road. And that's becoming a little disconcerting and difficult for some people to try to understand. And as we said, we are looking at more of a regional approach. If counties on the Western Shore are interested in keeping businesses closed for a little period of time, they're making those decisions at the county level. I'm just wondering if giving all the information the same way that health officers on the Western Shore are using that information, if health officers on the Eastern Shore, again, notwithstanding where the governor is right now, could provide advice to their county governments to say, hey, we might be able to open further or expand where we are in phase 1 and possibly into phase 2. So that's all. Thank you.
All right, you're quite welcome. And I see there are no other questions, but I wanted to raise one that has come up and affected a constituent of my district. There was a 15-year-old young girl who died from, it wasn't exactly COVID, it was something else, and it seems to pertain to young children. In light of many of our members have young children or grandchildren, I'm just wondering, is that something that the health officers are monitoring on a separate trajectory, or, I just want your thoughts regarding that. This, just like the first case, that my understanding is in Maryland for a young person like that, children.
Sure. In my previous life, before becoming a health officer, I was a pediatrician. And so the syndrome that you're talking about is recently there have been case reports across the country where children who I think a significant majority, I don't think all of them have, but a significant number have had COVID diagnoses, and they have developed symptoms that are consistent with a syndrome called Kawasaki's disease. That shows it's basically a significant inflammatory response, which causes inflammation of the vessels, particularly when we get concerned because it causes inflammation of the vessels around the heart, and it can cause aneurysms there. And so there are cases popping up. I know that Children's National has 7 or 8 cases there right now. We received a report yesterday that we have a resident, one of our pediatric cases may have those symptoms. I know in Chicago, where I used to practice before moving here, there are a number of kids in the Children's Hospital there. I say all of that to say that it introduces, as we move forward into the previous question about goalposts, I think as has been pointed out, we're learning lots of new stuff every day. And this is constantly evolving because if you think back to the very beginning, when we talked about children, we often said, well, if kids get it, they're going to be fine. They're mostly asymptomatic carriers. They're going to be okay. And now this changes a little bit. And so it's going to have to, think about how we look at pediatric cases, how we screen them, the guidance and advice we give related to children's activities. So again, I say all that to say that I think it's on everybody's radar, and we're likely to see more cases pop up, even in jurisdictions where there may not be a significant number of cases. And it's something that we have to, as this continues to evolve and we find out more, we have to be nimble in our response and think about how we can tailor messages to communities so that they understand the risks that are associated with the illness.
And building on that, I think that the other piece is that where this is different than the flu, and we initially compared it to that, but we're seeing that there's a lot of consequences of getting COVID that are not quite the same as flu. When you recover from the flu, there are very rare complications that continue, but we're seeing clotting disorders, kidney damage, heart damage that are consequences. So that's, we're keying in on the fact that deaths aren't the only adverse outcome from this. And so additional cases, as we're talking about the pediatric, but also in the adult, those complications mount as well. And I think what's so difficult about this is that we are learning along with you in real time what's happening. Mm-hmm. And that's not how we handle almost any other condition. The pace of change is unlike anything I've ever seen. And so we learn more, and as we try to share that does change how we're responding.
All right, see no other questions. I want to thank you both for your time and answering our questions, and and I wish you all the best, and hopefully we'll get to the light at the end of the tunnel on this whole thing. Thank everybody, and whether President wants to make some comments.
Sure. Just want to thank both health officers. Appreciate your expertise in sharing with us today. As the speaker said, just hopefully we get there sooner than later. I think all of us want the same objective. And so it's a matter of getting there the most efficient and effective way. So thank you. And then the only note that I have as a final remark is that to remind members to look at the hearing schedule on the website. There are a number of standing committees that have been doing more targeted and in-depth briefings, both in the House and the Senate. And so just a reminder to keep up to date with the standing committees on the Maryland General Assembly website.
And our next meeting is next Wednesday, May 27th.
We hope with the health department.
Yeah, with the health, yes.
Great.
Thank you, everyone.
Thank you, everyone. Stay safe.